Assalamu alaikum, everyone. So for those who don't know me, I'm Fahad Almehmadi. I'm one of the cardiac electrophysiologists from the National Guard Hospital in Jeddah. And over the next 20 to 30 minutes, I'll try to entertain people by showing a case of live in-box atrial fibrillation ablation using radiofrequency. And Dr. Faiz is not around. Okay, because Dr. Faiz is probably against point by point. So honestly, I have nothing to disclose for this presentation. So my objective is very simple. I just want to describe the case as it happened. I'm an Abbott user. In our center, we use both systems, but like I'm an Abbott user, so I'll be using Ensit X for mapping, Ensit X as a system, HD Grid for mapping, TactiFlex for ablation, and I use the ViewMate ultrasound where I can utilize it for both for TEE and intracardiac echo using the ViewFlex catheter. So I think the next, so this is our patient. And honestly, just a patient that we picked. He was scheduled, nothing special. So he's a 65 years old, who's your classic paroxysmal atrial fibrillation, who could not tolerate antiarrhythmic drugs that we tried because of bradycardia. His CHA2DS2-VASc score is 2. He's also hypertensive. He was not obese. His medications were valsartan and apixaban. Echo was more or less unremarkable. His left atrium was of a normal size, and blood works were all normal. And the patient had recurrent paroxysmal atrial fibrillation. So, because it's a longer case, so I just want to go over things of how we prepare a patient before, what do we do during the procedure, and what do we do after the procedure, just to give you guys the full picture, because it's not only the burning that happens inside the heart. So before the procedure, anticoagulation compliance is assured by our coordinators, anesthesia clinic for every single patient the week before, and we continue antiarrhythmics and beta blocker without any changes. And the last dose of anticoagulation, this is what I do. So we use apixaban in our center. They skip the nighttime dose of the day before the procedure, and usually our AFib are carried in the morning, and we start anticoagulation very early after with minimal interruption. And the patient usually fasts from midnight and come at 7 a.m. in the morning for the procedure where they get admitted. Because it's a video. Yeah, so I literally use minimal interruption. So when we talk about the procedure, we always start with anesthesia, our anesthesia team, and I don't want to say that I don't go into the lab, but it starts with our anesthesia team, and then I go over the access, the ice, and the transeptal preparation. Then we focus on the transeptal puncture with a lot of focus, and then we do our isolation. And for this patient, we had to do RA ablation in the form of a CTI line. So with our anesthesia, general anesthesia for everyone, I don't want people to complain about pain, arterial line for blood pressure monitoring and ACT monitoring, Foley catheter, and I always put 2 patches to lower the impedance. And almost everyone gets a TEE before we poke the skin to make sure that they don't have any clots. And we work very closely with our anesthesia team to play with the tidal volume, and we keep the tidal volume as low as possible as long as their CO2 doesn't go up. So then once this part is done, then the patient get draped, and then we'll get started like with the second part, which is access, ice, intracardiac echo. I'm a heavy ice user. Naeem was mentioning about the budget. So far, no one did an audit after my cases. I probably will be hanged if they do an audit. But I usually use ice heavily. So we get 4 accesses, 2 on the left for the ablation and the mapping catheter. 2 on the right for the ablation and mapping catheter, and 2 on the left. One we place the CS catheter, and the other one is a 10 French where I place the ice. And I give heparin half the dose right away. And I'll show you tomorrow in my ice talk why. I give half the dose even before the transeptal. Once the access is in, I give 50% of their usual dose. Then the next step that we do is we place the ice catheter, the CS catheter. And the CS catheter, we place it without the use of fluoroscopy. And we use the Navix mode. And I just want to show you how we do it. And this is actually done by my first-year fellow, not me. So we just advance the catheter, watch for resistance, and watch for signal. The moment that we start to see any signal, we know this part of the catheter is in the IVC. So we mark the spot. That's the spot where the IVC in. And then again, we advance the catheter slowly without the use of fluoroscopy till we lose the signal. So we know that we are in the SVC. So from there, we just flex, and we usually fall on the annulus, clock it on the annulus, and we are in the CS. So this is exactly what happens. So we flexed, and we are inside the coronary sinus, and we can see it from the signal without the use of fluoroscopy. And I think I took a single frame just to show everyone. So after that, I use the ICE catheter to pace the heart if needed, but I use it to guide my ICE catheter too. So the CS catheter is in, so this will help me insert the ICE catheter inside the vein without any issue, because the whole time, to make sure that I'm inside the lumen, I have to see my CS catheter. So I just follow my CS catheter all along. And even at the iliac bifurcation, I can just tweak the catheter with a little bit of flex. And this is done completely without the use of X-ray. I don't use X-ray completely because you can easily, with the feel and following your CS catheter, you can push the ice all the way in. So here, I can see the iliac going into the IVC. So while maintaining the catheter in view, I just pull anterior flex and then advancing, and now I'm in the IVC. I can see my catheter inside the IVC, and I just follow it because I know that the CS catheter is inside the heart. I just follow it all the way till I get to the inside of the heart. And once the ice is in, we always make sure that we have no pericardial effusion. We have the TEE that is done, but I always confirm it. This is what we call is our home view. This is our starting point with ICE catheter, where you can see the aorta, the right atrium, the right ventricle, and then getting into the RV is pretty easy. Just the one motion that you do again and again and again. We counter, flex, and advance, and we are inside the RV. And we can see that we have no effusion around the right ventricle, so we are safe to start. And I always record this at the beginning of the case as a reference, just in case if we develop an effusion later on, and we check around the LV. Now, we are done from this part and the flushes. So I know this is like something simple, but I don't trust the nurses. I think some of them are here in the room. I do it myself. So we arrange 3 flushes, and we put bubble traps, and these are the bubble traps that we use because we're going to be in the left atrium for a while. We use the Bipron Starfix, and I use the epidural one, and everything is connected to heparinized saline. So I'm showing this because I want to show people there is a lot behind that just going in and ablating. Now we do the transeptal, and honestly, I know people use TEE. I don't trust anyone to tell me where to poke. I want to poke because if something goes wrong, I'll be blamed for it, so I better know where I'm poking. So literally from the home view, I just rotate, and I can see the interatrial septum very nicely. I can see the left atrium, and I can see the pulmonary vein, and the mitral valve is completely closed. Then what we do, we advance the SL1 all the way up into the SVC, and we do our drop. And that's what I'm doing. Sometimes you can, so the next thing, we mark the Hess. So we forgot about marking the Hess because we want to make sure that we don't puncture the aorta. So the Hess is usually on the opposite side of the aorta. So we always mark the Hess catheter, the Hess location with our ablation catheter. And now I'm ready. The SL1 is all the way up. I always have a landmark where is the upper part of the LA, the lower part of the LA. The upper part of the LA is usually where the carina is. The lower part is usually where the CS floor. So this is more or less the LA. And where is my fossa is more or less somewhere in between the tip of the CS catheter, the ICE, and the Hess. So I probably don't want to go below the Hess catheter. That's my usual landmark when I do the drop. Everyone has its own way, but this is what worked for me, and I'm stuck to it. I use BRK1. I don't like BRK or the other vendor's needle. I use BRK1, and I always hook it up to a contrast and the short tubing for many reasons. So now we do the drop, and we can visualize it on ice, that you can see like I'm dropping, I'm tinting the septum here. So I know that like I'm in a really good spot for the puncture. And so this is a good spot. I'm away from the left atrium. So it is safe to puncture without running into complication. Now, before I do that, I always check on RAO. I do use a combination of ice and X-ray to do my puncture. I go in RAO, I make sure that I'm not too anterior, not too posterior, and I'm always parallel to my CS. And then we go back to the LAO, and then we do the puncture. So puncture with ice, it's beautiful. I have to say, it's not always this beautiful, but you can see that the needle is popping through the septum. So we know that we're inside the left atrium, and now the next task is to get the sheaths inside. So I keep injecting contrast, and I try to advance the dilator a bit. I pull the needle. The dilator is now inside the LA. Now I know that I maintain the hole. So now I do what Dr. Naim did. We put the wire always in the left upper vein, and you can see it also in ice. It's in the left upper vein. And now we slowly go serial dilatation. We're just trying to make the hole bigger to get the other sheath in. So here you can see I dilated the hole a bit. Now we try to get the ablation through the hole, which is usually pretty easy. We can watch the force. And after that, we try to dilate more. So you can see that our ablation is coming to the inside of the LA. So we had one catheter in. We dilate more to give space for the Agilis to get in. And then after that, I think it should be coming now. This is like further dilatation over the wire. We advance the Agilis. So now we have one sheath and one catheter inside the LA. And after that, we just advance the SL1, and we have a second catheter in. So we have the axis secured safely. We have both sheaths inside the LA safely. So now we can start and think about the ablation. And once I have everything in, I make sure that I have an annular signal. That's a practice we do in the center. I make sure that I have no effusion. Now it's time to give the full dose heparin because I know I'm safe. And honestly, I use this normogram after. So I have this printed next to the anesthesia machine. So we give the remainder 50%, and after that, they follow this normogram. So they do ACT every 15 to 20 minutes. Our patient's weight is 80 kg. So we were going to be working on this line. So let's say if the ACT in 20 minutes was, let's say, 210. So they give 5,000. They don't talk to me. I don't talk to them. I don't worry about it. This is what we agreed upon doing. So I talk to them when they change the tidal volume. But honestly, I don't have to worry about, okay, should I give 2,000 or 3,000? And it's almost like never works. So now we are inside the LA. We give the heparin. Now it's time to do the map. So the first thing I do when I do the map, I remember when I was a fellow, I got screamed on by my attending if I go into the appendage, because don't go into the appendage. So the first thing that I do when I map, I put the ice in, I see where my appendage is, I put the catheter in the appendage, I know where the appendage is, so I don't want to go in there. And that's what I'm doing here. So with ice, you can see my catheter is inside the left atrial appendage. That's the appendage. Don't go there anymore. And then I finish with my mapping. I do my map during CS pacing to collect more data. And here, I'm moving the mapping catheter on the back of the left atrium. I'm putting the catheter inside the left lower vein, and I'm going into the upper vein. You can see purple is normal voltage. And as I continue, I think this is where the case gets interesting. And honestly, this wasn't planned. When we got close to the right inferior vein, I just want you to focus here. See what happens as we get close to the right inferior vein. So when we get there, we get this rapid firing of atrial ectopics that happens just next to the right veins. Each time we go into the right inferior vein, we see this rapid firing coming from the right inferior vein. So this is probably was our money. So we said, okay, this is probably what's the trigger for this patient's AFib. So we just continued collecting the geometry by touching the wall. The catheter is very safe. You can't perforate with this catheter. Now we're going into the right upper vein. We're collecting the geometry. And each time we go close to this right inferior vein, we see this rapid firing again and again and again. So, and this eventually, this rapid firing, not surprisingly, caused atrial arrhythmia. And here at the beginning, you can see like the patient went into, started with this coming from the right inferior vein. That's probably like where the PAC started, all of the AFib. And then this patient went into this stable. At the beginning, it looks like a stable flutter proximal to distal. I said, okay, let's entrain. This is probably most likely coming from the right atrium. But entrainment, we saw like the post, like when we did the pacing, the post-pacing interval for the EP physicians like did not make any sense. And then we did it from the distal, like in the CS activation, kept dancing around. So I put my catheter on the back wall, and lo and behold, the patient was in AFib with what appears to be regularized activity in the coronary sinus. So we know we're in AFib. So we just ignore voltage collection because the patient was in AFib, and we just collected anatomy. So like you can see, like this is on faster speed. We're just trying to touch every wall of the left atrium just to get like a full geometry of the heart. And here, I think, and we got into the right vein. This was quite nice to see. Each time we go into the right inferior, even that the patient is in this AFib, we see this rapid firing coming from the right inferior vein. So we see it again here, we see it here, and here. So we know that the right veins are the money. Wael and I talks about if you start with the right veins or the left veins. I say, like we look at right veins as the dessert, and I go to Jizan a lot, and they start with the dessert when they eat. So they start with the fahsa. So I start with the dessert, and now I have a good reason to start with the right veins. So this is the full geometry of the atrium. Now I literally turn the X-ray off. I bring the old people chair. I take the lid off, and I literally sit for the ablation. And I call it the old people chair because when I say that, everyone want to leave the chair for me. So I sit down when I do my ablations. So for this case, I started with the right veins. The patient is in AFib. I know that cardioverting the patient will be unsuccessful given that the patient have triggers. So I said, okay, I'll start with the right veins, and I'll do this in AFib. And the catheter was actually pretty stable. This is our routine for the back wall. I use 50 watts for 10 seconds. Contact is about 5 to 30 grams. I aim for a good impedance drop, but like not too good, not more than 30, just for the risk of steam pop. And we just go point by point, trying to overlap the lesions just to make sure that we have no gaps. So we start on the back wall, we take it point by point, and every point takes about 10 seconds to do. And then we got intermittent sinus rhythm in between, but this is how we do it. We just point by point. It's therapeutic even for us. And then as we come around the inferior aspect of the right veins, the anterior walls, we go a bit more with a different power titration. So when we go on the anterior wall, we use 40 watts for a longer duration to get more transmural lesion because we don't worry about the adjacent structure like esophagus. And we use the same contact, the same impedance parameters. And we keep going through the anterior wall, going for overlapping lesions. And honestly, what helps us a lot here is the anesthesia. Because if you leave your tidal volume very high, you're probably going to see a lot of swinging motion of the catheter. So our anesthesia team, they know like we are ablating, the tidal volume will be the lowest possible just to help us with the stability with the ablation catheter. So you can see that like I'm trying to go all the way around to touch the other side where I started, just to complete the full circumferential lesions, what we call the right waka here. And I'll show, and the whole time I have my ablation, mapping catheter inside the vein just to see if I isolate it or not in real time. And the nurses are checking the flushes, the anesthesia are dealing with the ACT through the art line. So what I'm focusing on is just purely the ablation, and the team is doing everything else. So now the full circle is done, and I can show you, we got a transient sinus rhythm, but like here, we have the grid inside the vein and we see no signal. Someone will say, yeah, your catheter is too deep. But when we got into the right veins, the right inferior veins, we saw this rapid firing with isolated vein, so we know that we have done the job on the right. I think this is the 20 minutes that I have, and we'll finish like at the follow-up later. Okay.
Time for the question before we go to the next. Let's say stick Fahad for the questions.
Sure.
So let's open it. Ahmed.